Welcome to the deep dive. We're here to help you cut through the complex stuff and get straight to the key clinical insights you need fast. Today, we're tackling a really big one, a deep dive into respiratory tract infections, neoplasms, cancers, basically, and also the specific issues we see in childhood pulmonary disorders. Our goal here is to get you quickly up to speed on the pathophysiology, the mechanisms behind everything from, well, the common cold right up to some really serious global diseases. And this stuff really matters. I mean, look at the stats. Pneumonia, it's the 8th leading cause of death just in the US. And tuberculosis, TB, it's tied to immunity, poverty. It affects a third of the entire world's population. That's staggering. And then there's lung cancer. Still the #1 cause of cancer death worldwide, period.
Yeah. And what's fascinating here, I think, is that to really get why those numbers are so huge, you've got to zoom right in. Understand the immune response, how viruses actually work, replicate, and how fragile developing lung tissue is in kids. So we've broken this down into 3 main chunks for you. Infections first, then cancer, and finally pediatric disorders. We'll use the underlying pathophysiology, the how it works part, as our guide.
Okay, let's unpack this then. Starting with infections, there's such a huge range of severity here. Let's begin right at the top, the common cold. Sources say rhinoviruses are the usual suspects, and interestingly, it's not mainly spread through sneezing like you might think.
Right. That often surprises people. It's mostly your fingers. You touch something with the virus, then touch your nose, your eyes. That's the main route. Not so much breathing it in directly from a sneeze.
So washing hands is key then.
Absolutely fundamental. And clinically, the big takeaway for treatment. It's almost always viral. So rest, fluids, maybe something for fever, that's it. Antibiotics. Completely useless for a cold virus. It's crucial knowledge, especially for patient education.
Okay, so what happens when that cold kind of lingers or maybe allergies kick in and things move into rhinosinusitis, that sinus infection feeling? What's actually breaking down there?
Yeah, it's basically a plumbing problem. You've got these tiny little openings, the ostia, that drain your sinuses. When the lining swells up, usually from that virus or an allergy, those openings get blocked. Mucus gets trapped inside.
Creates a breeding ground, basically.
Exactly. Perfect place for bacteria to then set up shop. And we classify it pretty simply. Acute is up to 4 weeks, often bacterial like H. influenza. Chronic is over 12 weeks. And the chronic form, that can get complicated. Often involves different kinds of bacteria, maybe even fungi, and you can get irreversible changes in the sinus lining.
Okay, moving on to a real heavy hitter. Influenza. Flu. We mostly talk about type A, right? Because it's the most contagious.
That's the one. And it's all about those 2 proteins on the surface, hemagglutinin, or HA, and neuraminidase, NA. They're key.
They determine how infectious it is, but, they change. Which one are we more worried about changing?
Well, both, really. HA is like the key the virus uses to get into our cells. NA is the mechanism it uses to get out and spread after replicating. Vaccines target both. The changes are why we need new flu shots every year. That's mostly antigenic drift, small changes. But the big worry is antigenic shift. That's a major genetic reshuffle, like when an animal flu strain jumps to humans. That causes pandemics because nobody has any immunity. Big difference.
And pathologically, the sources mention the virus actually kills the cells lining the airway, the ones that make mucus and have cilia.
It does. It damages that lining directly. That explains the really runny nose, the cough, and importantly, it makes it easier for bacteria to stick around afterwards. Causes secondary infections.
Clears the way for the next problem.
Yeah, exactly. Which brings us nicely to pneumonias. Inflammation down in the alveoli, the air sacs, and the small airways, the bronchioles. We tend to classify them based on where you got it. Community-acquired, CAP, versus hospital-acquired, HAP.
Right. CAP is often S pneumonia, the common one. But HAP develops 48 hours or more after someone's admitted to hospital. The mortality rate is shocking, like 30 to 50%. Why so high?
It's really a combination. The patients who get HAP are often already very sick, right? They might be on a ventilator, maybe immunocompromised, just had surgery. They're vulnerable. And on top of that, the bugs causing HAP are often nasty antibiotic-resistant ones like Pseudomonas aeruginosa. So yeah, it's a really dangerous situation, much higher stakes than typical CAP.
Okay, if we switch gears and classify by the type of agent, we get typical versus atypical pneumonia. This gives more of a picture of what's happening in the lung tissue itself.
It does. Typical pneumonias are usually bacterial. These bugs live outside the cells and cause this massive inflammatory response with lots of fluid, or exudate, filling up the alveoli. This leads to consolidation, the lung tissue becoming solid. We call it lobar pneumonia if it fills a whole lobe, or bronchopneumonia if it's patchy around the airways. Atypical pneumonias, often viral or caused by bugs like mycoplasma, tend to affect the tissue between the air sacs, the interstitium. The symptoms are often a bit less severe, maybe more like a bad flu sometimes.
Okay, let's make that typical picture really stick. Can you walk us through those 4 stages of pneumococcal pneumonia, like if we were watching it happen?
Sure, it starts with stage 1, edema. Basically, fluid starts leaking into the air sacs, the alveoli. It's getting boggy. Then stage 2, red hepatization. This is really striking. So many red blood cells and inflammatory white blood cells pour into the alveoli that the lung tissue literally starts to look and feel solid, like liver tissue. Hence hepatization. Red because of all the blood.
Wow, okay, so it physically changes texture and color.
It really does. In stage 3, gray hepatization. The
Mhm.
red cells start to break down, but lots of white cells, especially macrophages, the cleanup crew arrive. The lung is still firm, but it loses that intense red color, looks more grayish. Congestion starts to lessen. And finally, stage 4, resolution. If things go well, the macrophages clean up all the debris, the exudate is removed, digested, coughed up, or drained by the lymphatics, and the lung tissue structure gets back to normal.
That whole process really highlights the intense inflammation, and that cleanup phase, resolution, that's kind of what fails in tuberculosis, isn't it? The body can't clear it.
That's a great way to put it, exactly. TB, caused by Mycobacterium tuberculosis.
Right.
It's a tough bug. Rod-shaped, needs oxygen, so it loves the upper parts of the lungs, and it has this waxy coat that makes it resistant to digestion by immune cells and makes it acid-fast and staining. But here's the crucial point. The main damage in TB isn't directly from the bacteria multiplying like crazy, it's mostly from our own immune system's reaction to it. Specifically, the cell-mediated immune response goes into overdrive.
And that response tries to wall it off, creating the Ghon focus.
Precisely. The Ghon focus is that initial lesion, usually small, gray-white, where T cells and macrophages surround the bacteria, forming a granuloma. They're trying to contain it. When that focus and the nearby lymph nodes draining the area are involved, we call that the Ghon complex. Usually the immune system wins, contains it, it heals, maybe calcifies, and the person has latent TB. They're infected, but not sick, not contagious.
And it can come back.
Yes, if immunity drops later in life, due to age, illness, medications that contain bacteria can reactivate. That's primary progressive TB or reactivation TB. This is when you get continued destruction, often forming cavities in the lung. Much more serious.
Okay, and this brings us to a really key diagnostic point, the skin test, the PPD or Mantoux test. What does a positive test actually mean?
This is so important. A positive tuberculin skin test only means you've been exposed to TB at some point, and your immune system recognizes it. You've developed that cell-mediated immunity. It does not, absolutely not, mean you have active contagious TB disease right now. You need other tests like chest x-rays or sputum samples to determine that. Big point of confusion sometimes.
Got it. Okay, let's wrap up infections quickly. The book mentions these 3 fungal infections: histoplasmosis, coccidioidomycosis, blastomycosis. They cause lung issues similar to TB, but they seem weirdly stuck in specific geographic areas.
Yeah, they're called dimorphic fungi. They can cause granulomas, look a bit like TB on imaging. Histoplasmosis you find in the big river valleys, Midwest, Ohio, Mississippi, often linked to bird or bat droppings. Coccidioidomycosis or valley fever, that's really specific to the desert southwest U.S. And blastomycosis is more around the Great Lakes, Ohio, Mississippi valleys again. Most people exposed don't get sick unless they breathe in a huge amount or their immune system is weak. But knowing where someone lives or has traveled is key if they have weird lung symptoms, right? Because the geography is so distinct.
That makes sense. Okay, that geographic link is a good transition. Let's shift gears now to our second big section, cancer of the lung. Tragically common, as we said. And the link to smoking is just undeniable, over 80% of cases. Plus industrial stuff like asbestos.
Yeah, the risk factors are stark. And clinically, the first big division we make is crucial. Small cell lung cancer, SCLC, versus non-small cell lung cancer, NSCLC. It dictates pretty much everything that follows.
How do they differ in terms of like staging and treatment approach?
Hugely. SCLC cells look small under the microscope, grow in clusters. It's very strongly linked to smoking, incredibly aggressive, spreads early. Because it spreads so fast, often microscopic metastases are already there at diagnosis. We don't usually use the standard T&M staging. We just classify it as limited stage, confined to one side of the chest, or extensive stage spread beyond that. And it's almost never cured by surgery alone. Chemo and radiation are the mainstays.
Okay, so SCLC is staged simply because it's assumed to be widespread early. What about NSCLC?
NSCLC is actually a group includes adenocarcinoma, which is now the most common type, often found in the outer parts of the lung, squamous cell carcinoma, more central, and large cell carcinoma. These tend to grow a bit slower, spread later than SCLC. So for NSCLC, we do use the detailed T&M system, tumor size, node involvement, metastasis presence to guide treatment, which might involve surgery, radiation, chemo, or combinations, depending on the stage.
And this is where it gets really weirdly fascinating, the perineoplastic stuff. The tumor itself starts acting like an organ.
Exactly. It's like the tumor cells remember how to make hormones or other bioactive substances they shouldn't be making. It's bizarre, but clinically important. SCLC is notorious for this. It can pump out ADH, causing SIADH, syndrome of inappropriate antidiuretic hormone, or ACTH, leading to Cushing syndrome. Sometimes antibodies that interfere with nerve function, like an Eaton-Lambert syndrome. Squamous cell carcinoma, on the other hand, is more known for causing high calcium levels, hypercalcemia, because it can make a substance similar to parathyroid hormone, PTH.
So the first signs might not even be lung symptoms, could be these hormonal effects.
Could be. Or often it's just vague stuff, initially weight loss, loss of appetite. Then you might get local symptoms from the tumor itself, irritating the airway, a chronic cough, maybe coughing up blood, hemoptysis, or symptoms from it pressing on things like superior vena cava syndrome if it blocks the big vein draining the head and arms, or hoarseness if it hits the nerve controlling the vocal cords.
And given that the average age at diagnosis is around 70, what's the thinking on treatment for older adults?
The key point the sources make is that decisions should be based on physiologic age, not just the number. How fit is the person? What are their other health issues? Can they tolerate the treatment? It's about their overall function, not just their date of birth.
That makes sense. Focus on the individual's health status. Okay, thinking about cell damage in cancer, it leads us kind of naturally to the other end of the lifespan, to situations where the fragility isn't from damage, but because things just aren't fully built yet. Let's move into our third section, respiratory disorders in children.
Yeah, and the big theme here is really developmental vulnerability. A kid's airway is tiny compared to an adult's, so even a little bit of swelling or mucus that might barely affect us can cause serious blockage for them. And remember, lung development itself takes years. It goes through 5 stages: embryonic, pseudoglandular, canalicular, saccular, alveolar. At birth, a baby only has maybe a sixth of the total number of alveoli they'll eventually have. They keep developing well into childhood.
And physically, the baby's chest is different too, right? It's more floppy.
Exactly. The chest wall is really compliant, very flexible, and the muscles between the ribs, the intercostals, they're not fully developed, not strong yet. This leads to something called paradoxical inward movement when they breathe in hard. The diaphragm pulls down powerfully, but instead of the ribs pulling outwards like in an adult, the soft chest wall actually gets sucked inwards. It makes breathing much less efficient, especially if they're struggling.
And that basic developmental fragility ties right into some key neonatal problems like respiratory distress syndrome, RDS. What's missing there?
The crucial missing ingredient is surfactant. It's a substance made by special cells in the alveoli, type 2 alveolar cells. It acts like a detergent, basically. Lowers the surface tension inside the air sacs so they don't collapse completely when the baby breathes out. But those surfactant-producing cells mature late in pregnancy, usually around 25 to 28 weeks gestation. So if a baby is born very prematurely, they just don't have enough surfactant. The alveoli collapse, making breathing incredibly difficult. That's RDS.
And then the treatment for RDS can sometimes lead to another problem later, BPD.
Right. Bronchopulmonary Dysplasia, or BPD, is a chronic lung disease we see in some preemies. It's thought to be caused by lung injury from needing long-term mechanical ventilation and high concentrations of oxygen treatments that were necessary to survive RDS. It's like a consequence of the life support needed early on.
Okay, shifting to slightly older infants and kids, there are 3 big infections we worry about, and telling them apart clinically is critical. Can we quickly contrast them?
Definitely. First, you've got viral croup, technically acute laryngotracheobronchitis. This is usually caused by parainfluenza virus. It affects the area below the vocal cords, subglottic. The classic signs are that seal-like barking cough and a harsh noise when breathing in, which is inspiratory stridor. It sounds scary, but it's usually benign and managed at home.
Okay, barking cough, inspiratory stridor, that's croup. Then there's epiglottitis. Sounds serious.
This one is serious. It's a true medical emergency. Usually bacterial, like H. influenza type B, though less common now thanks to the Hib vaccine. It causes rapid swelling of the epiglottis, the flap above the vocal cords. The child looks sick, really toxic. They often drool because it hurts too much to swallow, sit bolt upright, leaning forward, chin thrust out, trying to keep the airway open. And the huge safety point here, the concept mastery alert in the text, is never try to examine the throat or make the child lie down if you suspect epiglottitis, unless you're in a fully controlled setting, like an OR with intubation equipment ready. It can trigger complete airway closure. Instantly fatal. Wow. Okay, critical distinction. Barking cough is croup. Toxic drooling sitting forward is epiglottitis. What's the third one? The third is bronchiolitis. This is an infection of the lower airways, the tiny bronchioles, most often caused by RSV, Respiratory Syncytial Virus. Here, the inflammation and mucus down in those small airways traps air, so the main problem is getting air out. This leads to a prolonged expiratory phase and the characteristic sound of wheezing.
Okay, so the sound tells you where the problem is. Croup gives you stridor, that high-pitched crowing on inspiration, meaning upper airway blockage.
Right, and bronchiolitis gives you wheezing, that whistling sound, usually on expiration, meaning blockage inside the chest and the lower airways. Understanding that difference is key.
And if any of these kids get really bad, what are the absolute warning signs? The signs of impending respiratory failure?
Yeah, there are definite red flags. You need to watch for severe retraction, skin sucking in deeply between the ribs or above the sternum with each breath. Grunting noise when they breathe out, that's them trying to keep airways open. Also, cyanosis turning blue, especially if it doesn't get better with oxygen, extreme anxiety or agitation. And then either very, very rapid breathing or suddenly slowing down, becoming depressed. That's often a really bad sign, means they're tiring out. Those mean call for help immediately. Got it. Okay, so what does this all mean? We've really covered a huge amount today, haven't we? From how a cold virus gets in to the immune battle in TB, how cancer cells misbehave, and why kids' lungs are just fundamentally different. I think the connections that stand out are things like how SCLC needs that completely different staging approach compared to NSCLC, or how that positive TB skin test isn't the whole story, and just the basic physics of why a small compliant airway makes children so vulnerable.
Absolutely. And if we connect this to the bigger picture, knowing these specific pathophysiologies, viral mechanics, granuloma formation, surfactant function, it's not just academic. It's crucial because these respiratory problems, as we said at the start, they represent enormous global health burdens, illness, death across all ages. Understanding how these diseases work at a fundamental level is the only way we can diagnose effectively, treat appropriately, and develop better public health strategies. That really brings it home. So maybe a final thought for everyone listening to mull over. Think about how those massive global efforts fighting drug-resistant TB, creating new flu vaccines every single year, how they depend entirely on scientists and clinicians having this deep, detailed understanding of the very immune responses, genetic changes, and cellular processes we've been talking about today. It all connects. Thank you for joining us for this deep dive.